I am an emergency physician at the Cambridge Health Alliance in Massachusetts.
Okay. How did the Cambridge Health Alliance come about? What's the mission and history behind that?
Yeah, CHA is the last remaining public hospital organization in Massachusetts. So it started as the City Hospital of Cambridge. And then over the last couple decades, they've also acquired the Somerville Hospital, which is primarily outpatient now, as well as the Everett Hospital in Everett, Mass. And they have those hospitals as well as several primary healthcare centers around the sort of North Metro Boston area. And their primary mission is to be a safety net hospital to serve the underserved in the community.
Yeah. And I know Boston hasn't hit the peak of the coronavirus yet. When do you anticipate that peak, and what has it looked like at your hospital up until now?
I don't know exactly if it has hit the peak. I think we're pretty close to it. I think the estimates are that the peak is happening right about now. And if we haven't gotten there yet, we're approaching it, hopefully quickly. And so we've definitely been in the middle of the surge over the last couple weeks. So CHA, in particular, because of the communities that we serve, we've seen a lot of COVID-19 patients. At least 2/3 of our patients for the last couple weeks have been COVID-19 patients. Of all the patients we have in our hospital, about 2/3 are admitted specifically for that, which I think is at times the highest percentage in Massachusetts. So we've been at pretty much full capacity. They're doing a very good job of sort of turning over inpatient beds and ICU beds and creating more beds and expanding, as well as collaborating with other hospitals in the region so that when our ICUs are full and when our floor beds are full, we can transfer back and forth to other hospitals. But it's been busy, and it's been a lot of work, and it's been very anxiety provoking. But I think the system has been responding impressively well, and people have been working together really well. So I've been heartened to see how well things are sort of coming together for our patients.
Yeah, that's really good to hear. And I want our conversation to really center kind of globally around the situation regarding immigrants and refugees and people in confinement or in close quarters that they
Mhm.
can't escape. And oftentimes, people in poverty can't escape uh, poverty because of systems in place, and they can't escape the places where they live. But because you're a safety net hospital in a major urban center that's been affected by the coronavirus, I want to know. Uh, you I know a lot of the information that we get from hospitals is somewhat anecdotal because we don't know everyone who has contracted the coronavirus. We know that it affects people of color disproportionately and people
Mhm.
who are from lower income households. But is everyone getting the treatment that they need from safety net hospitals? Are they going to hospitals, or are many of them remaining at home or in shelters without even knowing that they have the coronavirus?
That's a good question. I don't think we have that data very well yet. I know that in Boston, certainly seeking. There's lots of people who are seeking care, even who are impoverished or homeless, or coming from jails and detention centers. Whether that's all of them, I don't know. Whether or not they're presenting later than folks who have more freedom of movement, or who are living in their own homes, is a good question, and probably worth studying, but I don't know the data on that right now. I think there's a lot of reasons to worry more about those populations in terms of their access to care, in general and across the country and across the globe, because if at baseline your ability to access the healthcare system is not great, then that's going to apply in the pandemic as well, in particular when people are more reluctant to seek care at baseline because they're afraid of the virus.
Right. And you mentioned that you're one of the last safety net hospitals in Cambridge. And I can assume that if patients who don't have access to healthcare or equal access to healthcare, having home quarantine options is an equally difficult struggle. So, the burden is not only on, for their personal health and safety, but also the health and safety of the people around them and the general public. So
Yeah.
they can't follow certain public orders to stay at home if they don't have a home, right?
Well, there's a few mechanisms at work, I think, that are really applicable to these populations, to these patients. So one is that, particularly amongst working class people and amongst the immigrant populations in the United States, a lot of those folks are essential workers, right? They are the people who pick the food on the farms, who deliver the food. They are the grocery store clerks. They are the ones who are doing the shopping, the grocery shopping for people and doing deliveries. So a lot of those guys, a lot of those people are out in the community, out getting more exposure than folks who are staying in their homes. And a lot of them don't have access to adequate PPE. I think there's a lot of attention that goes towards nurses and doctors and healthcare workers and our ability to access enough PPE, which is itself a fraught issue. But there's been very little attention, I think, towards these other essential workers who are feeding the population and facing high rates of exposure. So there's that. I think another issue that we're seeing a lot in Boston is that a lot of working class families, including immigrant families, but also non-immigrant families, live in multi-generational homes. So particularly in urban areas where housing is expensive, if you are not particularly wealthy, it's a lot harder to live in a home that has, just a nuclear family. So you're a lot more likely to have your parents, your grandparents living with families and nieces and nephews and cousins, and more people in a smaller space. So it's both a space issue and it's the multi-generation nature of it, because the highest risk patients are the people who are older. They are at higher risk of getting exposed if they're living with their younger family members. So there's that as well. Yeah, so there's a few things, and then when you think about people who, there's other subpopulations like the homeless population, who oftentimes their only safe shelter is in a homeless shelter. The circumstances and logistics about how those shelters are structured may put them at higher risk of exposure. Say nothing about jails and detention centers where people have no ability to social distance.
And so globally, as we think about the numbers from the coronavirus increasing into the millions and millions over time, there are a lot of people who are unstably housed and varying economic strata who will be affected and continue to be affected by the coronavirus. They won't be able to avoid contracting it, and they won't be able to access adequate treatment for it all around the world. And just to give a sense of the size and proportion of that population, can you talk a little bit about the globally displaced population and what their living situations look like around the world?
Yeah, I mean, I think it's important to keep in mind that when we're talking about displaced people, there's a few different categories to think about. So overall, the United Nations High Commission for Refugees, the UNHCR, who keeps, I think, the best track of these numbers, they estimate about 70 million people are currently forcibly displaced from their homes. The majority of those, about 41 million, are in their home country still, but internally displaced. And then about 26 million are refugees, which by definition means you've crossed an international border and you're in another country. And then a very small proportion of that, about 3.5% or 3.5 million, are asylum seekers. And so it's also important to keep in mind that of the refugee population, people who have crossed international borders, the vast majority of them are in countries that border their home country. So the biggest host countries in the world are Turkey, who's hosting a lot of people from Syria, Pakistan, who's hosting a lot of refugees from Afghanistan, and Uganda and Sudan, who are hosting a lot of refugees from South Sudan. So, I think a lot of people in the United States, maybe their mind goes straight to the refugees seeking asylum in the United States, and that's an important population as well. But on the numbers game, when we're looking at refugees and internally displaced people, we're looking largely at people who are in host countries that themselves are lower middle income countries with limited resources and a much harder time kind of absorbing that refugee population.
And many of these individuals can be in formal camps that are designated by the United Nations, but sometimes, like the homeless population in the U.S., they might be camping out or living on the streets. I know in the past I've seen abandoned factories that were makeshift encampments where there were just bed sheets separating rooms for families, and how possible is it for someone to, I mean, we know how to avoid contracting the virus generally, which is stay 6 feet or more away from people who aren't in your nuclear family. And if you go 14 days without contacting anyone and you don't have symptoms of the virus, you're in the clear, and you've just got to
Hmm.
maintain that social distance. And that seems like our foreseeable future, right? But how can you do that if you are going to a job and you're not able to get into more stable housing with some privacy in a private bedroom even?
Totally. Yeah. I mean, yeah, it's impossible. It's impossible for a lot of people to actually stay that far away from other humans. And so, of course, their risk is going to be really high.
And,
Yeah.
and one of the things that I'm concerned with is, with 70 million people in this precarious position of not being able to socially distance, I mean, out of necessity, they, I mean, they could possibly, become the future carriers of the virus, and they're either not counted because they don't have equal access to healthcare, and they're not treated. And
Mhm.
it becomes sort of the forgotten narrative of the coronavirus, because what we are hearing are really touching and heartwarming stories and heartbreaking stories from the middle and upper class families. But what about the stories of the poor that get forgotten in this?
Yeah, absolutely. I mean, I think even in the United States, when you look at the cities that have had bigger outbreaks and they're trying to look back and analyze their mortality data, for example, you can see the mortality bump over what is the sort of baseline expected mortality, and only maybe half of those are documented coronavirus cases. And so it's a really important question to ask of those folks who died who are not coronavirus documented cases, how much of that was actually coronavirus that you didn't catch? How much of that was them dying from other things that they couldn't get access to care, or they had a harder time getting the treatment that they needed because this outbreak has so disrupted our medical system and our response system? We don't really know the answer to that. But yes, I think that people who have historically been forgotten and ignored are still forgotten and ignored in this pandemic, and in particular are even more vulnerable than they have been historically.
And this is a unique situation. I mean, I think it's true in all cases, but it's amplified in this one, where the health and well-being of people of lower income brackets, it directly affects everyone else's public health and well-being. And so, if you can't care about this out of basic human decency and the dignity of people, you can at least care about it from the perspective of public health and keeping your own family safe. So I wonder, what if you are in a shelter setting? Maybe it's jail, maybe it's a immigrant detention facility or a refugee camp, or you're just living rough in a tent encampment somewhere. What are some things that you can do to keep yourself safe? And I just want to acknowledge really quickly that we're doing this online, and there's this assumption that people who don't have houses don't have access to the internet, or that they shouldn't have access to the internet. But
Mm-hmm.
oftentimes, if you can't afford rent, or if you can't be in a home, the next cheapest thing that you can to feel human and feel connected to society is to have a phone and have an internet. So, I do
Totally.
hope that this is circulated among some communities where it can be helpful. So if you could give us some tips on how to stay safe, that'd be great.
Yeah, I mean, I think well, I think each of those settings is unique and poses different challenges as well as opportunities in terms of creating safe settings for their clients and constituents. But also, I would say to start with people themselves, everyone should be trying their best when they are capable of maintaining distance from other people, wearing a mask if you are out in the community. So the face masks that we ask people to wear in many communities in the US are not so much about protecting yourself from others, but it's more about protecting others from your respiratory droplets. So whether or not you actually have a cough, if there's any chance that you might have asymptomatic coronavirus or you haven't yet developed symptoms, the idea that the science is starting to support is that if you're wearing a mask, the respiratory droplets from you speaking and talking and clearing your throat are less likely to get out and infect others. So if you have access to a mask, wear a mask whenever you're around other people. Wash your hands as much as possible, in particular before you're going to touch your face or eat. Um, And then to the extent that you have any ability to have conversations with folks who are helping to provide you with housing and shelter and anything like that, advocate for social distancing and safe spaces. And so to that end, I would say when you're looking at the people who have power over these facilities and sort of in trying to structure them in safe ways, you can sort of think of them each individually, right? So shelters themselves, like homeless shelters, depending on the actual logistics of the facility, some of them can sort of be rearranged to allow for social distancing spaces. A lot of communities are seeking out other shelter spaces for their homeless populations so that they can separate out people who are confirmed positive for COVID, who are suspected to have COVID, and who have been cleared COVID negative, as well as creating, for particularly for the COVID positive or suspected, giving them actual quarantine, isolated spaces, separate rooms and things like that. And if you can create a shelter where you have that, and especially so that you can observe the sick patients and catch them when they do feel like they're getting sick enough to go to the hospital, and in the process of that, providing them with food and basic supplies, that's really the best option. So they're doing that in Cambridge. They've basically opened up a new building space where they can separate out the groups in that way, and that's really great for us in the healthcare system because we have a safe way to discharge people who don't have to be in the hospital right away. With encampments, it's a little bit trickier because you're dealing with sort of autonomy issues, and oftentimes people who live in encampments are very suspicious of authorities or any sort of attempts to exert control over their spaces. But particularly if there are organizations that work in close communication with people who live in encampments, they can oftentimes provide supplies for hand hygiene. They can help them sort of rearrange their tents so that they're farther apart, and they can do teaching and education. You can't assume that just because people are living in encampments that they don't want to know how to protect themselves. So doing outreach and sort of working with them to figure out ways to create their space to be the safest way that they can is encouraged. And then finally, with jails and prisons, I would say that the biggest step that a lot of people are pushing for is decarceration. So actually anybody who doesn't need to be in jail should not be in jail right now. And so, there's a lot of people who are in jail who are awaiting trial. They're on nonviolent charges. They have families they could go home to. And so I think people need to be thinking very carefully about how many people can we safely let out of jail and let out of prison, and not, we're not letting them off the hook or out of the justice system, but they can come back for their court date. They don't have to sit in a jail cell around a dozen other people and create this public health risk. They can be at home with their families and then come back to court later. And the same goes for immigration detention centers. Most people who are in immigration detention are not violent. They did not actually commit any crimes. They did, immigration laws are civil laws rather than criminal law. So I think there's a lot to that as well, in addition to sort of trying to spread out the prisoners in these in jails and prisons.
Yeah, I think Rikers Island, their suggestion was that inmates sleep head to toe to keep their mouths as far away from each other as possible. But in a podcast by the New York Times, The Daily, yesterday, one inmate was medically vulnerable and appealing his release from prison, wanting to be released early from prison. And in the time of making the podcast, he had contracted the coronavirus. So just amplifies the difficulty of the situation in these close quarters, in these settings where people have really, really limited movements and freedoms. And it's a threat to us all. So, what happens when there's not, even adequate funding for PPE or for a separate quarantine room where someone can isolate themselves, is that for the most medically vulnerable, they will become oxygen dependent on something like a ventilator, which we know is in short supply. Does that mean that they will more than likely just be going to an ER, really burdening our public health systems even further? And then does a place like does Cambridge Health Alliance have a ventilator, or what are you doing with patients that are in need of that sort of
Yeah, we absolutely have ICU beds and ventilators, as do private hospitals around the state as well. And one of my favorite things about being an ER doctor is that by law we're not allowed to turn people away. Thank goodness, because I don't think I could do that. I don't think I could practice medicine where I turn people away.
Yeah.
And so, yeah, I mean, if you need care, you're going to get care. There have been some laws that have been passed that are trying to protect people who don't have insurance or are losing insurance because they're losing their jobs, like so many millions of Americans, and not having to pay for the medical expenses related to COVID. And this goes for the most vulnerable of our society members as well, for the homeless, for the people who are victims of human trafficking, for the people really living on the margins. They are welcome to come and seek medical care, and we will take care of them as best we can.